Moving on to normal anatomy, as I told you, and you can see it in this loop quite nicely, start always at the clavicle. Move down the clavicle until you reach this view. As soon as you reach the heart, you do stop and take a bit of time to evaluate the normal anatomy again. What we can see here is close to the transducer, the right ventricle. This is the left ventricle. The ascending aorta you can see already parts of. This is the aortic valve, the right coronary cusp, and this is the non-coronary cusp or left coronary cusp. Here's the left atrium, the anterior mitral valve leaflet, the posterior mitral valve leaflet, and the posterior lateral wall. This is already the anatomy you can see. The coronary sinus is located over here, but it's really small, so sometimes it's not even possible to visualize. Pay attention if you have right heart failure or elevated pressures in the right heart, you might already see the coronary sinus in this view to a larger extent. Adding color Doppler in this image is already very important. You can first place the color Doppler on the mitral valve, so you shouldn't do it on both valves at the same time. So record one loop with the color Doppler across the mitral valve. You see here a little bit of a mitral regurgitation. This is not uncommon to see, so you don't need to be worried about that. But keep it in mind that in the parasternal long axis view there was a tiny or mild mitral regurgitation, just to take another look in another view. Second, place it across the aortic valve. Here you see the aortic valve. Also across the aortic valve there is an insignificant jet. So you see here a tiny jet as well. Still keep it in mind to scan it in more planes. So the parasternal long axis view is also really an entire overview of all the structures you can see in the heart. So some small or minor pathologies we already found. As I mentioned, you basically should place the color Doppler across one valve at a time and record 2 loops. I do understand that in daily clinical practice sometimes that's very hard to do because you at least feel stressed. Even if you are maybe not stressed, there is always a lack of time to scan more patients because patients are in need of the exam. So what you also can do alternatively, but still I wouldn't recommend it, even though I have to admit I do it in my daily clinical practice, as you can see here as well. Place the Doppler, the color Doppler across both valves, and here you can see the mitral valve and the aortic valve. Still, you should try to avoid it and scan each valve individually. This is another healthy example, and in this example you see that here is, for example, the descending aorta. There is also probably some mitral regurgitation present over here. Over the aorta I do not see regurgitation at all. There's also blood flow in the right ventricle. One more important tip I want to give you is that the color Doppler shouldn't be too broad. So the area of interest or the region of interest should be really small. The length doesn't matter, but if you make the color Doppler very, very broad, you lose frame rate. So make it as narrow as possible, but that you still see all the important pathologies you want to visualize. So in case of mitral regurgitation, make it as broad as needed to visualize all the regurgitation, but don't make it too broad because you will simply lose quality. Moving on to another structure I wanted to show you towards the ascending aorta. So how do you scan the ascending aorta? Well, it's basically very easy. So sometimes you just scan it in a normal parasternal long axis view. If not, simply move one intercostal space up. And if you do that, you will be able to visualize the ascending aorta over here. Measure it, and if it's above approximately 38 millimeters, it's pathological. The ascending aorta also should be documented in each and every echocardiographic exam. There are some more standard views you have to acquire in case of the parasternal long axis view, and one view is focused on the aortic valve. It's quite natural that if the aortic valve does have a pathology, you want to visualize as much of the structure as possible. So you should zoom in to specifically see the aortic valve. And this is the aortic valve. Here you see the ascending aorta. This is the alveoli, so the left ventricular outflow tract. There's again the right coronary cusp and the non-coronary or left coronary cusp. So focus a view on the aortic valve. You can see that the aortic valve is calcified, the cusps are calcified, but the opening of the aortic valve still works fine. The second view you have to acquire after the focus of the aortic valve is the mitral valve you want to focus on. So you want to focus on the anterior part of the mitral valve leaflet and the posterior part of the mitral valve leaflet over here. In this loop, you have to focus on the mitral valve. So zoom into the mitral valve, try to visualize the opening and closure of the anterior mitral valve leaflet and the posterior mitral valve leaflet. If it's opening quite nicely, that also points you towards a normal left ventricular function, as we have seen in all the examples before. If it doesn't do that, or if there's a restriction or a doming of the mitral valve, you might see stenosis already, even in the B-mode image, or get hints towards mitral regurgitation. This concludes the first part of the normal anatomy of the peristernal long axis view. We will move now on towards the pathological findings and another a very important topic, the atypical views. If you did like this video, please follow me on Instagram, on Facebook, LinkedIn, ResearchGate. I'm also doing a lot of research about ultrasound, especially strain imaging. See some cases on my YouTube channel, and I will be happy to answer your comments.